Good evening and welcome everyone to the first Lexington Medical webinar on current developments in thoracic surgery. This webinar series will provide insights into the latest advancements in thoracic surgery, starting today with the topic of resection of radiologically subsolid invasive T1 and 0 adenocarcinoma. We appreciate your participation and look forward to an engaging and informative discussion. We are also honored to have Professor Servet Bölükbas, Head of the Department of Thoracic Surgery and Thoracic Endoscopy at the University Hospital Essen, Ruhrland Clinic, Germany, as our presenter today. Welcome, Professor. Professor Bölükbas has a robust academic and professional background. He has also been actively involved in building and leading DKG-certified lung cancer centers, emphasizing patient-centered care combined with advanced thoracic surgical techniques. His expertise extends to minimally invasive procedures, with over 85% of surgeries at his current clinic being performed using these methods. Professor Bölükbas is also recognized for his contribution to the development of multimodal therapy concepts for thoracic oncology, particularly lung-preserving resections. In addition to his clinical work, Professor Bölükbas is a prominent figure in the European Society of Thoracic Surgeons, serving as a board member and treasurer. His research interests are reflected in more than 120 scientific publications and book chapters. He has contributed to international guidelines for the diagnosis and treatment of pleural mesothelioma and has presented over 100 papers at international conferences. So I would like to hand over to Paul, our global marketing manager, to talk a little bit about Lexington Medical. Thank you.
Thank you, Rolf. Thank you, Rolf. Thank you to all of you for joining. And of course, thank you to Professor Bölükbas. My name is Paul Rabinovich. I lead our marketing team here at Lexington Medical. And I'm just going to spend a few moments telling you about our company before diving in. Lexington Medical is a Boston-based medical device company. We were founded in 2013 by our CEO, Leon Amarillo. Leon is a medical device veteran and entrepreneur with over 30 patents to his name. And Leon believes, and we at Lexington Medical believe, that the surgical stapler is a critical tool, especially to thoracic surgeons like yourselves, and that the surgical device is one that deserves innovation, and it is something that Leon set out to do, and we have been doing for the past decade plus. So how have we achieved this? The first is specialization. So at Lexington Medical, we do not make trocars, we do not make clip appliers, we do not make advanced energy. We focus on one product and one product only, and that is the surgical stapler. Our team of world-class engineers wakes up every morning, goes to bed every night, thinking about how we can perfect that B formation and how we can deliver the best staple line in the world. We focus on continuous improvement. So what we like to tell our customers is that the Aeon endostapler you are holding in your hands today is different than the one you would have been holding in your hands a year ago, and it is different than the one that you will be holding in your hands a year from now. And that is because we are continuously improving our product and launching new SKUs and products to meet the needs of our surgeons. And our innovation is informed by close collaborations with surgeons around the world. We believe in controlling our destiny. So in order to deliver the best-in-class product, we need to design the product ourselves. We need to manufacture the product ourselves. And not only do we make our own products, we make the smart manufacturing capabilities in-house in Bedford, Massachusetts. This has allowed us to deliver a best-in-class stapler and has also allowed us to have a very robust supply chain that always delivers the product on time and has had 0 back orders since our product was launched in 2018. And ultimately, our goal and all of our goal here is to improve patient outcomes. Our goal at Lexington Medical is to transform surgical stapling technologies so that chest tubes can come out sooner, so that the rate of prolonged air leaks can be reduced, and so your patients can go home sooner. And with that, thank you very much. I will turn it over to a man who needs no introduction, Professor Bölükbas. Thank you.
Great, thank you. Maybe we can go on to the next slide and one slide more and start with our question. Now use your cell phone, please, and make your choice. I will see the results soon. Okay. More people can be involved. I have here 19 votes, 21 votes. Okay. The majority would go for a lobectomy, followed by anatomic segmentectomy, and a minority would go for a wedge resection. Okay. Then we can move on with our presentation. One more slide. Next slide, please. Okay, where we are coming from. Let's look at the past. Next slide, please. Our perception and our daily practice is based on this trial. It was published in 1995. This small randomized trial was done at Memorial Sloan Kettering in New York. Please, next slide. And what we see here, the colleagues by that time compared limited resection with lobectomy because of the recurrence rate and local regional recurrence rate, death with cancer, death with all cases. It was accepted. Next slide, please. And based on this survival curves, where lobectomy did better than limited resection, but after more than 3 years after the resection. Next slide, please. The conclusion and recommendation for the coming decades was that there was no, that this study has failed to demonstrate the equivalence of wedge or segmental resection to lobectomy, and lobectomy with systematic hilar and mediastinal lymph node sampling or dissection should remain the standard surgical treatment for such individuals. Next slide, please. And nowadays, we have a lot of new evidence. Next slide, please. Let's look at this study. This study was published last year in February in New England Journal of Medicine. There are only few studies published in this prestigious journal coming from thoracic surgery. Next slide, please. The colleagues conducted a multi-center non-inferiority trial where they looked at peripheral non-small cell cancer and had two groups in terms of segmentectomy or wedge resection group compared to lobectomy. Next slide, please. And as you see, importantly, it was a T1A tumor. That means tumor size was equal or less than 2 centimeters. And it took more than 10 years to get this data and more than 6 more follow-up years to get this paper published. A lot of work. Next slide, please. I don't know why it's in German, but the methodology, it was a randomized phase 3 non-inferiority study. 83 centers from USA, Canada, and Australia took part in the study. As I said before, it was a tumor sized 2 centimeters or less, and it was a clinical stage 1A1 or 1A2. And it was recommended and required that during the surgery intraoperative staging was performed to confess clinical N0 stage. And the most important stages were for the lymph nodes were 4, 7, 10 for the right side, and 5, 6, 7, and 8 for the left side. Next slide, please. And if you look at this data, we can see that most of the patients were in a good, healthy status. Most of the patients were white. Next slide, please. And importantly, female gender was the predominant gender, and only few patients had ACOG status 2. And most of the patients were current smokers. Next slide, please. What about the consort diagram? More than 1,000 patients were screened. At the end, 697 was randomized, and 357 patients underwent lobar resection, and 340 patients underwent sublobar resection. Next slide, please. You can move on, please. And importantly, sublobar resection consisted of 60% of wedge resections, and the majority of the approach was minimally invasive. Next slide, please. The primary endpoint was disease-free survival, and as shown here, there was no difference. 5-year survival-free rate was 64.1% for lobar resection and 63.6% for sublobar resection. Next slide, please. And importantly, you can go one forward. One back, please. Importantly, if you go to the low volume centers in this study, your probability to have a 5-year disease-free survival was approximately 60%. But if you go to high volume centers, your probability to have a disease-free survival of 5 years was almost 70%. That means you as a patient has to decide where to go and where to undergo your surgical resection. Next slide, please. And if you look at the overall survival, there was no statistical significance. Next slide, please. And if we look at the secondary endpoint, the reduction of pulmonary function, there is a difference, but not as expected. The difference is very low between lobar and sublobar resection. Next slide, please. What about the recurrences? There is also no real difference between two groups. Next slide, please. Based on this study, the conclusions were that patients with peripherally located tumors sized 2 centimeters or less and pathological confessed N0 situation do not have an inferior disease-free survival, and the overall survival was similar in both treatment modalities. Next slide, please. But 1 year or 2 years before, there was another Japanese study. Next slide, please. If we compare both data, it's very surprising. If you check the data, if you undergo lobar resection with the same condition in North America or Australia, your 5-year overall survival probability is almost 80%. If you go to Japan, it's almost 90%. There is an important difference between the survival rates, not only because of the surgeries, but most probably also because of the genetics. Next slide, please. Now we have more and more evidence. Lung cancer is not lung cancer, and pulmonary nodule is not pulmonary nodule. Therefore, we have to define what we find on the CT scans. On the left side, you see a pure GGO or GGN It's called ground glass opacity or nodules. On the right side, you see a pure solid tumor. And in between, there is different possibilities for the occurrence of the nodules. And depending on the solid side of the tumor and the ground glass opacities, depending on the distribution, it's part solid, and the figure is CTR. It means consolidation to tumor ratio. Next slide, please. And one of the most important papers this year was the extent of surgical resection for radiologically subsolid T1N0 invasive lung adenocarcinomas. This is the background of this presentation. Next slide, please. And here you see the flow chart. It's a study with a span over 12 years with almost 18,000 patients screened. And at the end, after applying all the inclusion-exclusion criteria, almost 260 patients underwent wedge resection, and almost 1,250 patients underwent segmentectomy. Next slide, please. And what we see here is how the distribution of the patient was. CTR ratio equal or below 0.25 to CTR ratio above 0.5. Next slide, please. And if you look at the data, let's go to the left side. We have a CTR ratio below or equal 0.2.5. That means it's more ground glass opacity. You see up to 2 centimeters disease-free survival and lung cancer specific survival. It's almost 100% for both modalities in terms of wedge resection or segment resection. It's also true for disease-free survival if you go above 2 centimeters, up to 3 centimeters. But there is a survival difference for lung cancer specific survival. It's 90% versus 100%. If you go to the right side, that means more or less solid tumors. And there is a difference in disease-free survival also for tumors up to 2 centimeters. And if you go above 2 centimeters, there is no statistically significant survival difference. Next slide, please. In summary, if we look in this chart, we see if we have a small tumor up to 2 centimeters, it depends what the CTR ratio is. If it's up to 0.5 centimeters, there is a statistical signal that wedge resection could be an option for these patients. It's not inferior, but if we have a more solid tumor, that means CTR ratio above 0.5 or tumor above 2 centimeters, there is a survival difference. So anatomic resection is the resection of choice. Next slide, please. So if we make it very easy, wedge resection in this case and no wedge resection in the other case. Next slide, please. If we look at long-term outcomes after lobar versus sublobar resections, we have also a systematic review, but there is only a few studies who are randomized, only 5 studies, but there are also 13 propensity score match studies. And if we compare 2,100 lobar resections to almost 2,000 sublobar resection, we can say lobar resection is better for overall survival, but there is no significant difference in disease-free survival or 30-day mortality or cancer recurrence without matching. But after matching, there is no significant difference between lobectomy and segmentectomy. in terms of overall survival and disease-free survival. But lobectomy do better at the end for the long run. Next slide, please. If we talk about resection, we also have to talk about lymph node dissection. And this study is hot off the press. It's almost, it's in press, not officially published, but this goes in the same direction. Next slide, please. As you can see, this is also a contribution from Japan. Japan is very active in this field, and you see they have almost 1,000 patients included in this study. Patients were included in this study who had clinical early stage in terms of CT in situ, CT minimally invasive, CT1A or CT1B. 21% were retrosections, 38% were segmentectomies, and 42% of the patients underwent lobectomy. Next slide, please. And after surgery, it turned out to be adenocarcinoma as the leading cause of the disease in 99%. And if you look at the PT stage, there was an up stage, but to stage 2 or 3, it was only 2.3%. If we look at the N factor, only one patient had N1 after preoperative and intraoperative staging, and nonetheless, 4% of the patients underwent adjuvant treatment. Next slide, please. And if you look at the statistics, if we look at the lymph node dissection, there was a difference how it was applied. That means patients undergoing wedge resection had almost no lymph node dissection. Patients undergoing lobectomy had a systematic hilar and mediastinal lymph node dissection in 62%. And if we look at the dissected lymph nodes in the bottom line, you see patients undergoing lobectomy had in median 10 dissected lymph nodes, but in wedge resection, 0. Next slide, please. Nonetheless, if we look at overall survival and recurrence-free survival for the complete cohort, we see a very high overall survival rate of approximately 79%, and a disease-free survival also ranging in the same range. Next slide, please. And if you look at the different treatment modalities, on the left side, overall survival, we see there is no difference between wedge, segmentectomy, or lobectomy. And if we look at disease-free survival, it's also not significantly different, with approximately the same numbers 5 years after surgery. Next slide, please. So if we look at this picture once again, any surgical procedure without lymph node dissection is feasible if the surgical margin is secured in patients with GGO dominant tumors, is the conclusion. Next slide, please. But what about quality of life? It's very important for us to know what's the quality of life for our patients if they undergo different treatment modalities. This study looked at minimal invasive surgeries for patients undergoing segmentectomy or wedge resection. If we look at this data in terms of pain, there is no difference. In terms of postoperative cough, there is no difference. In terms of shortness of breath, no difference. Disturbed sleep, no difference. Next slide. If you look at fatigue, dizziness or distress, also no difference. Next slide. But what is different? Different is the surgical outcome in terms of if you undergo wedge resection, the operative time is shorter, you have less intraoperative bleedings. The drainage time is shorter or equal in this case for wedge or segmentectomy. The postoperative stays equal, complication rate is not different, but the total cost is inferior for wedge resection. Next slide, please. What about the current guidelines? Next slide, please. My favorite guidelines are from the NCCN guidelines. Why? It's up to date. There are many versions. You see version 11 for this year. But nonetheless, you see in this guideline the signals we received from the ongoing studies. It's not in this guideline. There's still no room for this wedge or sublobar resections in this chart. But next slide, please. If you go in detail and read the principles of surgical treatment, then we recognize that segmentectomy and wedge resection should be strongly considered for peripheral T1, A, B, and 0 tumors. We recognize that sublobar resection should achieve parenchymal resection margins greater or equal to 2 centimeters or more or equally the size of the nodule. And sublobar resection should also sample appropriate N1 and N2 lymph node stations. And segmentectomy or wedge resection is appropriate in selected patients with poor pulmonary reserve or other comorbidity then contraindicates lobectomy. It's against the results of the studies because in the presented studies, the patients did not have inferior or pulmonary reserves. Next slide, please. Based on the new evidence, an expert group was created from the AATS, and an expert consensus document was presented. And I wanted to show you the main issues about these guidelines. Next slide, please. There is a change in terms of surveillance and diagnosis. It's recommended that we have ideally 1 millimeter slices that we can evaluate the GGOs appropriately. We should repeat CT scans at 6 months for non-solid tumors less than 6 millimeters. If we have persistent non-solid nodules, then we should perform more frequent examinations. And for stable subsolid nodules beyond 5 years, it's still recommended to perform surveillance. Next slide, please. And if you have nodules above 8 millimeter with concerning features, then we should do at least a closer surveillance or tissue sampling. And if the nodule is above 8 millimeters, showing growth, biopsy or limited resection is recommended. And in these cases, it's surprising for me, MRI, bone scan, and PET-CT is not indicated for non-solid nodules less than 3 centimeters as part of preoperative evaluation. It's against the recommendations in Germany, at least. Next slide, please. What about the surgical intervention? Sublobar resections are reasonable for peripheral subsolid lesions less than or equal to 2 centimeters, and above 2 centimeters lobectomy is recommended. And if we have positive margins in frozen section, then we should go for segmentectomy or lobectomy, depending on the previous resection. And for subsolid cancers diagnosed with adenocarcinoma in situ or minimally invasive adenocarcinoma, annual surveillance is recommended. Next slide, please. And finally, if you have managed multiple subsolid nodules, the most dominant lesion should be targeted for biopsy to get an information about this tumor. And if we have multiple subsolid nodules, a combination of surgical and non-surgical treatments might be appropriate. Next slide, please. So once again, after heard this new evidence, all this new information coming out from the studies published recently, how would you go for this situation? Which kind of resection would you perform after these studies? Wedge resection, anatomical resection, or lobectomy? Please vote. And I tell you the results. Okay, still the leading part, or the treatment of choice is still lobectomy, followed by wedge resection and followed by segmentectomy. Thank you. Then we can proceed with next slide, please. Which kind of lymph node dissection would you prefer for this kind of tumor shown on the CT scan? You have to scan this picture once again. It's a different poll, and we look at the results. Okay. Systematic lymph node dissection is leading, followed by no lymph node dissection and lymph node sampling. Thank you. So next slide. I'm sorry, this is a wrong slide. Next slide, please. To sum up, we have evidence that for subsolid nodules size 2 centimeters or less, wedge resection could be equal to the known anatomic resections or lobectomies. We have evidence that no lymph node dissection might be appropriate for pure GGOs equal or less than 2 centimeters. But however, these results are not implemented in all guidelines. That means there is a lot of room for discussions in this webinar. I'm happy to share my ideas and talk with you about your ideas about this topic. Thank you for your attention.
Thank you very much, Professor Bölükbas. We would open up the system for question and answers, please.
So the micros are now unmuted. If you have any questions, feel free, and you also need to click on your micro to say something.
Hi, it's Michael Schweiger from University of Lübeck Hospital. Thank you for that excellent talk. Very, very great presentation. Thank you. You were talking about that a wedge resection is appropriate for non-solid tumor less than 2 centimeters. And you were explaining also the benefits regarding quality of life. But if we as surgeons now talk that we do very limited resections and quality of life, shouldn't we go for radiation, for a stereotactic body radiation therapy? Then we avoid the surgery completely, and life quality of life might be even better. What's your opinion regarding this?
Yeah, thank you, Michael, for this question. It's a very important question because we compete with non-surgical treatments if we treat very, very early stage lung cancers. You are right, quality of life is the driver at the end, but a lot of patients want to get rid of their tumor undergoing surgery. And the advantage of the surgery is having also the tumor biology. We know the type of tumor. We know that it's completely resected. And at the end, if we achieve very low or very, very low morbidity and mortality, I guess we will win the race. But we have to be very, very cautious not to lose the patients to non-surgical treatments. You're absolutely right. What is the perception of other thoracic surgeons out there at this meeting? Oh, I see Volkan Köşek from Lünen has a question or raised the hand.
Professor Bölükbas, it's very, very nice to hear you and your presentation. I have a question to the GGOs. What is your opinion about navigation bronchoscopy? Will it be in future more a tool in the thoracic surgery to use, or do you think that we stay in Germany for a long period without navigation bronchoscopy as we do nowadays? Or what is your opinion? When will we start with currently or more often doing navigation bronchoscopy? Thank you very much.
Thank you for your very important question. We're in the lucky position that we have a navigation bronchoscopy on site here at our institution. Nonetheless, it's not performed in every patient, only in selected patients. But they have also their disadvantages. If you have tumors close to the pleura, the risk of pneumothorax is high. If you have nodules in the apical segments, it's hard to get there because of the limits of the bronchoscope. One possibility could be this robotic system from another company, but it's very expensive and only 2 systems are implemented in Germany nowadays. That means there is a very long way to go.
Hi, Professor Bölükbas. This is Paul. Not a thoracic surgeon, but I have a question nonetheless. So you mentioned you showed data from Japan with lobar and sublobar resections and very, very good 5-year survival rates. And you mentioned this may be a genetic contribution. Do you think there's also any difference in screening guidelines in Japan that may be contributing to better survival rates there?
This could be, but I'm not familiar with the Japanese guidelines. Therefore, I do not have an answer on that. But we have also industry in the room. At the end, which kind of treatment is paid is depending on quality. Quality means quality adjusted life years. That means how much money I have to invest in a treatment to get an optimal treatment with the best quality of life for the patients. And I guess if you apply surgery, at least in Germany, and you pay only 10,000 euros for everything, it's very cheap compared to immunotreatment, which costs you 2,500 per year lifelong.
Yeah, that's something we hear all the time in all the countries. That's a very important topic, I would say. What is in the DRGs and to count everything together. Thank you. That's interesting to see. And from my side, it's as a non-doctor, would be good if we would have screening programs, as far as I could understand. As earlier you can detect, or as smaller as the nodule, obviously, then the treatment is easier, and the healing rate is great. So is that a program in Germany, or is it inside that you have screening programs here?
Yeah, we have screening programs, but nowadays it's still as part of a trial, because in Germany it's not allowed to apply CT scans on healthy people, because if you apply the CT scan, you don't know about their cancer. That means they are per definition healthy. And it's a huge mess to get a permission from the authorities to get permission to perform CT scans. Nonetheless, the first steps were done. That means maybe next year or the following year, there will be a huge launch of screening programs across the country, at least in Germany. And then we hope that we detect more patients in early disease. If you look at the Nelson trial, the results are comparable to real-world data. If you look at the certified lung cancer centers in Germany, nowadays 50% of the patients have stage 4 at diagnosis of lung cancer, 50%. And in the Nelson trial, where screening was applied, 50% had stage 1. That means there is a great shift of the patients to early stages with higher probability of survival than in the past. And that drives also industry, pharmaceutical industry, because more and more patients get also systematic treatment in terms of drug treatment in early stages if they have some risk features which is predictive for recurrence.
Yeah, very interesting. And maybe if you can work out that screening programs in Germany, we have probably the possibility to see that in other countries as well. So I keep finger crossed.
Yeah.
So if no more questions occur, I would like to hand over the speak to Thomas Baumann, our Therapy Development Manager for Germany, and he has something to tell about our educational and clinical education programs.
Yeah, thanks, Rolf, for introducing me. Before I start, just one question from my side. I'm interested in a program of incidental findings, Professor Bölükbas. Do you know if we have something looks like that in Germany?
I don't have these figures for Germany, but I know in US, they started screening programs 15 years ago. Because of the incidental findings, it was for free. A CT scan for free, because if you go to Johns Hopkins, you get a CT scan, you don't have a cancer, but maybe you have calcification in your heart, and then you go to the cardiologist, and then you get a diagnostic workup. Therefore, at the end, there is reimbursement for the CT scan because of the incidental findings. But I don't have any data on incidental findings in Germany.
Okay. So we have to work on, maybe. Thanks for that. Yeah, I just try to share my screen. Hopefully it works. So can you see my screen?
Yes.
Good. Yeah, it's a pleasure for me just to show you in 2 slides what we are doing in Germany for thoracic training opportunities. Not only for Germany, maybe, but also for European countries, or maybe at the end for a global opportunity. So we are increasing our program monthly, but we're starting now in Germany with these 3 clinical immersion centers, and I would just show you what we are doing here. We divided our program into 3 topics. The first one is the topic of lung volume reduction. We are doing this in Germany with Dr. Morris Beschei. He is a surgeon in the city of Bielefeld in North Rhine-Westphalia. The second topic what we are providing is the main topic of Watts segmentectomy, but also lobectomy. For this topic, Professor Bölükbas himself is our partner to provide clinical immersion on that way. And the third one is the topic of non-intubated Watts courses. So the topic of non-intubated Watts surgery is there's a high interest in Germany, but also in other European countries. So I got a lot requests during the last weeks. And this is doing Dr. Patrick Sado from the Medical High School in Hanover for us. If you are interested in a detailed agenda, maybe you can scan this QR code and you will get the agenda and a short introduction from each lead of these clinical immersions for these courses. So that is the first way what we are doing from Lexington with our partners. And the second way is cadaver training, what we're providing in collaboration with Opus Skills. We are doing this on different diseases together with Dr. Daria Jäger. She's the organizer and the founder of Opus Skills. I think Daria is also on the call. We are providing together with Opus Skills courses in liver surgery, in pancreatic surgery, other diseases, but yes, of course, in thoracic surgery. This cadaver course is the second one. What we are doing, the next one is this month. So this week, tomorrow, I think we will start, right? With Watts thoracic surgery on 5 tables. And the second course is in January with trachea resection and sleeve resections. So if you're interested in one of these opportunities, please feel free to contact your local representative from Lexington for Opus Skills. You can see here the email address from Opus Skills, or you can Google this maybe in the internet and have the link from Opus Skills. That's from my side all what we are doing just now. We increasing, as I said, our program day by day. If you are interested in something additional, also please free to ask us and to speak to us. Yeah, thanks for that. I give it back to Rolf.
Thank you very much, Thomas. I thank you, Professor Bölükbas, for your very interesting talk. I thank to the Lexington team, Kerstin, Paul, and Thomas. And I wish everyone a good evening and hope to see you soon here. Goodbye.